There's a new study out on tirzepatide and heart, and I thought this would be a good time to go over with you the evidence, because you'll probably hear that there's better evidence for semaglutide, which is Ozempic or Wegovy, than tirzepatide, which is Mounjaro or Zepbound for the heart. So let's talk about what the studies show and what kind of studies they were. The newest study was just published 2026 in the British Medical Journal, looked at nearly 53,000 adults with type 2 diabetes, and they already had cardiovascular disease. They were then either taking tirzepatide or sitagliptin. This was observational, real-world study. That means that they didn't randomly assign people to the medications. Instead, they looked backward at what had already happened to people who were prescribed those drugs in routine clinical practice. That is useful because you're seeing real world results, but it has the limitations that you can just find an association and not a causation. And this is one of the problems with this research. So investigators used sitagliptin as the active comparator instead of placebo, and it wasn't a randomized prospective controlled trial. But despite that, after 1 year, the risks of major cardiovascular event was 2.9% with tirzepatide versus 4.4% with sitagliptin, which is another diabetes medication. So 1.4% points different. And so that's one fewer event for every 70 people treated for a year based on that observational data. So tirzepatide looked good compared to sitagliptin, but because this wasn't randomized, we can't say this is definitive proof of cardiovascular benefit. So what other studies have been done with tirzepatide? The SURPASS CVOT, that was a randomized controlled cardiovascular outcome trial, which sits much higher in the evidence hierarchy. That had more than 13,000 people with type 2 and established heart disease, and they were randomly assigned to either tirzepatide or dulaglutide. That's another GLP-1 that is used to treat diabetes. We don't actually use that for obesity. So it wasn't against a placebo. Dulaglutide has already been established that it does have lower cardiovascular disease in outcomes trials. So investigators were asking, is tirzepatide at least as good as this other GLP-1 that we know has good benefits? The primary endpoint was MACE, major adverse cardiovascular events. The hazard ratio was 0.92. Confidence interval crossed 1. That means that tirzepatide was not inferior, meaning that it wasn't worse than dulaglutide. So, but it wasn't superior than dulaglutide. So, tirzepatide was demonstrated to be cardiovascularly non-inferior to dulaglutide, which is good cardiovascularly. So, if they would have done it against placebo and shown that benefit, we could say, but we can just say it's non-inferior. So that's a pretty good study showing it was just as good as dulaglutide. But we also have earlier tirzepatide evidence in the SURPASS-4. That was a randomized, controlled phase 3 trial. They looked at tirzepatide versus insulin, glargine, in type 2 diabetes with a high cardiovascular risk. MACE was not increased with tirzepatide. The hazard ratio was 0.74. And the confidence interval also crossed 1. That means it's not statistically significant. So that trial wasn't designed to prove cardiovascular benefit, but it did look at like glycemic control. Cardiovascular event was part of the safety assessment. So there was a pre-specified pooled analysis of 7 SURPASS trials. They also found no cardiovascular safety signal, but they weren't designed to establish cardiovascular event reduction. So not great studies to prove it. And there's another fascinating piece with the tirzepatide, heart failure with preserved ejection fraction we called HFpEF in people with obesity. That was the SUMMIT trial, randomized placebo-controlled trial, so stronger evidence. In this population, cardiovascular death or worsening heart failure occurred 9.9% with tirzepatide, 15% with placebo, hazard ratio of 0.62. The reduction was primarily driven by fewer worsened heart failure events. And there were just too few cardiovascular deaths to compare that tirzepatide reduced cardiovascular mortality in HFpEF. Patients also had improvement of symptoms, physical function, inflammation markers, body weight. So this is strong, randomized, controlled evidence for the benefit of obesity in HFpEF, treatment of that, but you can't probably generalize that to every person with heart failure. So why does semaglutide have a broader cardiovascular evidence? Why do people still say semaglutide has more mature cardiovascular evidence? Because semaglutide has several placebo-controlled cardiovascular outcome trials designed to specifically test cardiovascular event. SUSTAIN 6, that was randomized people with type 2 diabetes and high cardiovascular risk to semaglutide or placebo. There's a 20% relative reduction in MACE. Then we have the SOUL trial. That was another randomized placebo-controlled cardiovascular outcome trial studying oral semaglutide, people with type 2 and established cardiovascular risk or chronic kidney disease. That also demonstrated significant reduction in cardiovascular events. And then there was the study that really changed the conversation, which was the SELECT trial. That enrolled more than 17,000 adults with cardiovascular disease and overweight or obesity, but not diabetes. Semaglutide in that study reduced the risk of cardiovascular death, heart attack, stroke by 20% compared to placebo. So it's important because it demonstrated cardiovascular benefit in population where the indication wasn't just you have diabetes. It showed that in people already with heart disease and excess weight without diabetes, they had a lowering of cardiovascular disease. So that's why, because it's the way that the studies were designed. You see how important it is to understand the design of studies. So semaglutide, therefore, has the broader definitive cardiovascular outcomes evidence because they were multiple placebo-controlled, large prospective superiority trials in showing that benefit. So tirzepatide has good cardiovascular evidence too. It's not that it doesn't have any evidence there. Like I pointed out these trials, but they're not, the studies weren't designed as well to prove it. Comparing it to dulaglutide, comparing it to insulin, just not as, the studies weren't made to show that. So we do not have a randomized head-to-head trial showing semaglutide is superior to tirzepatide for heart attack, strokes. We have that study looking at the two of them for weight loss and other things, but not for cardiovascular outcomes. Hope that's helpful to you guys.